So thank you very much, Ruth. Thank you for having me. I was asked to come and talk to you a little bit about our journey in Dorset as on our way to becoming an accountable care organisation system, and then potentially an organisation in the future, but also about the clinical journey that I've been on. I'm still a working GP. I've been a GP for 25 years, now senior partner in my practice. I'm well aware of the stresses and strains that we're all under as a system. And I'm very focused on patient care. And I suppose my journey through the last 3 to 4 years, really, leading in and working in Dorset, has been very much around the whole system and trying to bring care together. So I'm just going to give you a quick reflection on Dorset. When I was reading your STP on the train down last night, I was reflecting really that we've all got very similar problems, very similar challenges. None of this is particularly new, and you'll be going through exactly what we were going through as well 2 to 3 years ago when we started embarking on change. So I think the difference is we have one CCG, so we're coterminous. We have one governing body with a number of localities, 13 localities, and we've clustered them into a Mid East and West. We had over 100 practices when we started. We're now down to 86, and that's because the smaller practices have just felt the need really to merge into larger practices, and very much the way forward, I think, in terms of sustainability. We've got nearly 800,000 people and a budget about £1.2 million. So we've got very similar challenges, very common themes, and our STP looks really remarkably similar to yours. I think fundamentally for us, it was around when we started this journey in 2014, and I would say that we have had the benefit of time to get to where we are. This was very much around understanding what our challenges were and undertaking a clinical services review. You talked about clinical strategy a moment or two ago, and I'll reflect on that in a minute. That led us really into our sustainability and transformation plan. So I suppose we went from a clinical strategy and then really started to embrace the local authority and social care and the voluntary sector into our world, and including public health and the importance of that as we went forward, which then enabled us to create a very comprehensive plan going forward, and then we went to public consultation. We've become a shadow accountable care system in the summer of this year, and we are going to take that on from the shadow form that we're in now going forward. And what I would say is this is just all about conversations, this is all about communications, and this is all about system working. So our accountable care system really is there to deliver our sustainability and transformation plan. So I'm just going to go back one moment. I think the really important thing that happened to us a few months ago is that all of our organisations signed up to a collaborative agreement, and that effectively drove a whole new way of working and a whole different conversation between organisations. Whilst we are no longer under a PBR tariff, effectively, it started to drive a different way of working, different conversation about how we deliver care. Now, fundamentally, in our plans and in our accountable care systems, we need to keep our eye on the fact that this is all about patients. This is about saving lives, it's about better care, it's about better quality of care and care closer to home. And so as a whole system, we are now on that endeavour. And for a system, this is about being sustainable going forward. We've got immense financial challenges, like everywhere else in the country, and this is also about our workforce. And if I were to reflect on what one of our biggest challenges is, it's going to be absolutely about the workforce being able to take those plans through. And we're working very hard on how we can try and embrace new care models as part of this. And I would suggest that it is our one opportunity now in a generation, I guess, to join up together with health and social care and address some of the wider determinants of health. We've got some of those same gaps that you have here in Kent. And if you talk to our public health colleagues, they remind us often that in terms of healthcare and improving healthcare of any population, around 10 to 20% is probably around the actual health services that exist. Around 30% is about the life choices that people make around smoking and alcohol and exercise and so on. And 50% is around the wider determinants of health. whether you have a job, whether your house is good, is it warm, is it damp, and so on. And so I think as a whole system, it gives us an opportunity to start having those really important conversations that lift the health of the population, and we start to address prevention in a much more meaningful way. Okay, now a little bit about what clinical leaders can do, and I'm aware that there will be some clinical leaders here as well as other management and other local authority and social care voluntary sector leaders. But I would say that having worked with clinicians over the last few years, there are some real things that clinicians can bring to your vision and helping you with your strategy, because inherently they will aspire to have the very best quality, and they will help you create your vision. By nature, they're good communicators, and one of the real successes in my system has been to try and allow very small areas to grow organically from the bottom up, to actually create the vision that they want for their local area, and use a bottom-up sort of organic growth approach to helping focus on the care of that particular population. And I think that we can create that right environment for teams to be able to take that forward. They can flex and negotiate, and they are very good often at creating the right relationships. So clinical leaders can be very important to you, but I don't think that we can work without very good managers as well to help us develop some of these plans. So when we started out with our clinical services review, and I will dwell on it because it actually was really fundamentally important to the way that we were able to go forward with this. We started at the beginning looking at acute care, and arguably that was not the right place to start. We started a lot of discussion around how we were going to configure our 3 acute hospitals. If I were to do it again, I'd start absolutely in the community, because fundamentally some of the assumptions that we made around how we were going to reconfigure our acute hospitals was not possible without having a really good underpinning community strategy. So when we started to aspire to moving 20 to 25% of acute medical admissions out into the community, of course you can't do that unless you've got the community resilience and the response that someone asked earlier on. So having a very clear strategy for community is absolutely essential. And then following on from that, we very quickly went into what were the issues around general practice, and how were we going to start to be able to create a primary care strategy at the same time. What we've ended up is a community and primary care strategy to help us deliver some of those changes. So we started our clinical services review with around 600 clinicians in clinical working groups. And we started by having a look at actually where were we in the whole, what were our outcomes. And it was a bit of a shock to me to realise that actually we didn't have very good outcomes in some areas either. So you alluded to stroke. We also didn't have very good outcomes in stroke. London was a much better place to be if you wanted a good outcome in stroke, and that's quite shocking. So you need to know where you are, and then we started to look at national and international best models of practice. And through a series of clinical working groups, which were system-wide, we started to evolve a vision, really, for what our future might look like in terms of health and social care. So it was clinically led, it was management supported. We had GPs like myself leading many of the working groups, and going month after month after month, and trying to then reflect back to the system, take their views, bring that back to the next working group. It's a very, very time-consuming process, but one that you just can't shortcut, and you need to be able to have those very honest conversations. There was a lot of co-production. We had numerous reference groups, clinical reference groups. We had workforce reference groups, estates, finance, and patient and public reference group all the way through. And really importantly, we worked as commissioners and providers together. And I think one of the things we need to think about is having protected time to do this. You can't do this on top of the day job. You really need to be able to have some heads-up time and space to allow that learning and that relationship building to come. So we often ran these groups in the evenings, because actually there's no other time that you can get a lot of people together. We gave them food, we allowed them to talk, and we allowed that key relationship development to happen. And what really struck me at the beginning of that journey was that actually nobody really knew each other. People didn't know each other from the acute trust. They certainly didn't know each other from across the system, across Dorset, and had very little knowledge of the local authority counterparts as well. So it was a very good way of starting to build those relationships. Following on from those clinical working groups, and we still do have them, we've run a series of what we call transformational conversations, so deep dives into specific areas where we've thought that actually we need to spend a bit more time. And interestingly, people keep on coming, 80 to 100 people keep coming to those conversations as we emerge them. So what are our challenges? This is really complex. We're working across a system in a very complex and changing way, and we're dealing with a lot of ambiguity along the way. We've got different worries around governance, around CQC, around different organisations. And I would say that one of the key learnings for me has been how to actually recognise and understand what happens with our local authority colleagues, and how we can work better with them. One of the key challenges very early on was that we didn't even speak each other's language. We didn't have the same view on what a locality was, what a patient, a citizen, all of those things, and very different governance arrangements as well. So get to know your local authority colleagues and get to know them quickly, and you'll find then that it becomes much, much easier. There was quite a degree of resistance to change that happens. People feel a loss, they don't understand, and it can be very difficult to take people on that journey. And people have very big organisational alliances, and some of that can be very, very difficult to break through. I remember we all violently agreed on the model of care, and it all fell apart a bit when we started to come down to site-specific options. So be aware and very gently try to have those very honest conversations. We've also got a very disillusioned and very tired workforce, and so to engage with people at grassroots was actually very, very difficult, and that takes a lot of time and planning. And we found that even when we thought that through our clinical leaders who are coming to our working groups, we thought all of that had been fed back to organisations, when we actually came to some decision making, we realised that actually that communication hadn't happened, and then we had to go back and do quite a lot of that again in terms of engagement with our clinicians and our organisations. Financial challenges remain. Again, I think this collaborative agreement that we've all signed up to has meant that we are having a different conversation about productivity, about making the best use of resources. Public and political influences have been very significant for us, and they will be for you, and I'll talk about that in a minute, and also about the challenges of the media. So coming to those then, I would say that the things that I've learnt have been some about the people that we work with across a range of areas. So first of all, around our peer group. So our peer group can be very passionate. They see the future often very clearly in their specific area of work. They're often very driven. They are also highly critical of change and will very much want to see the best for their own service and their own patients, and don't always see the bigger strategic and system picture. And we need to make sure that we take people through a journey of that, understanding that and helping them to kind of see that. But they're also very highly influential. And so one of the key lessons for me was around making sure that we engaged with the right clinical leaders who were able to help us influence and drive that. There are a number of clinical champions that I think you will find in your own organisations and as well, who will be able to help you drive those changes through. In terms of the public, my advice would be to engage again, and consultation and the time and effort needed to undertake really proper, valuable consultation cannot be underestimated. So don't cut corners in any of that. We did a very long period of pre-engagement before we even went to consultation. And after consultation for our various changes, we went back and reflected for a period of 3 or 4 months over what people had said to us before we made any decisions. And I think that was very, very powerful, because it was meaningful and people really did then feel that they had been very part of this. We were very transparent with any changes that we thought we might be making, and I think, again, that was very valuable to us going forward, because when we actually came to decision making, there was no big ta-da moment, because actually most people were aware of the things that we had been discussing, and we'd been discussing and co-producing that with them. But they also can help the public, and I think they should be part of any co-design process going forward. The press were very difficult at times. The press will always want a good story, and I think one of my lessons as being a clinician in all of this is to have some media training quite quickly, and then do it again, and then really start to try and understand and develop some relationship with our media colleagues, and be very, very prepared for all the eventualities that you can possibly be there. And then in terms of politicians, another very important group, and when we're thinking about system-wide change, and I think the development of key relationships with your political colleagues within your system is really, really important, because they will want the best for their population. It's really important that they understand any changes that you are making. They also can be very helpful for you in taking forward the messages to the public as well, and delivering them in the way that they can interpret with you and for you. And I think one of the other lessons I learned very early on was to make sure that with my local MP, I let him know if I thought something was coming forward that he should know about, because being prepared in their world is very, very much better than having to be left answering questions without really the benefit of the knowledge. And that was really a key and important factor for me. So factors for success. So we were named as an accountable care system, and I think that's partly because of the targets. I'm not under any illusions. It's around delivering the targets. It's about being in financial balance. But I think also our factors for success were about having a really clear vision and belief in what we were doing. This does give us an opportunity really to change the way that we deliver care. I haven't talked much about productivity and technology, but I think it's really exciting that we can start to really embrace a different way of working. Clear leadership, both clinical and executive management leadership, has been essential when we came to giving our latest governing body a meeting where we made some really key decisions around the future for the next 20 years really in our system. We had our clinical leaders taking part in that, but we also had our chief execs standing up and endorsing that this would work, that this was the right system. And that's very, very powerful for the public, because the public also need to have confidence that they understand what you're talking about, that you know that you're doing the right thing, and that they believe that it will work. So that's really, really important around that leadership and that culture and values as well. I've said before, I don't think that you can underestimate the time it takes to develop key relationships, and I would pay huge attention to both that and also to communications. I don't think we've even got communications right now, and I would urge at every really important meeting that we have somebody interpreting from the comms team what does that mean, both for the workforce and also for the public. You need committed teams to be able to deliver this with some dedicated project support, because you can't do this without giving it that amount of time and energy, really. And also support emerging leaders as they come forward. There will be new people who will step up to these challenges and be able to really help you take your system forward. So just finally, just a thought on how did it go. At times it was really, really hard. At the end of it, I'm very proud of what we've achieved in Dorset, and I feel that although we still have a very long journey ahead of us, this is really just the beginning. I believe that we do have a very clear vision going forward for what we want to achieve, and I think we're in a very much better position in terms of working across the system as a whole. And I do believe it will create better care for patients going forward. It will be difficult, and there will be new ways of working, but we will have to work that through. As I've said, We did have dedicated support teams, so a big project management team, and we did have help from external partners. And that actually gave us a kick start and a momentum for change that we would not have had if we had just done it all by ourselves, really. We led the review, we believed in the review. When we continue, there's been a real consistency in leadership, and I think that's been very helpful. Everything costs, everything was funded internally. We didn't have anything given to us. We had to pay for all of it. I've talked about the huge time commitment. There were protests along the way. But I think that at the end, you will have to be in this. There will be things that you need to work through. But my vision really would be for you to be in there and help shape it to go forward. And you just need to keep going, because actually you only fail when you stop. Thank you.